Thank you, ma'am, for the introduction. And really, though the hall is empty, but I'm actually thrilled because from where I started my journey in 1998, coming from Shamnagar, place from where probably nobody was there from in medical college. I was the first person from that particular place, and after that, this journey to now what I am. Now I'm working in the Department of Nephrology, IPGMER, doing transplantation. Last we did ABO incompatible transplantation, first of its ever or its kind in government setup. That I took the initiation and ultimately we did it. And so this journey actually started from here, and whatever I learned, that actually is from here. The courage and the enthusiasm for doing any work, that I learned from here, and that's the teachers and those over there. And I must congratulate and thank Ovik and Anirban for organizing this spectacular reunion, probably first of its ever kind in 190 years history. So this topic is actually probably a complicated topic, osteoporosis and CKD. But why I just mentioned or trying to say something about this, because it is actually not discussed anywhere in any place, in any forum, though it's a medicine or in surgery or nephrology or endocrine, because osteoporosis in CKD is a neglected one. But osteoporosis per se, which is defined as a fragility fracture, when the bones becomes very much fragile, and so you will have a fragility fracture. A trivial trauma can have a fracture, maybe in the hip, maybe in the spine, maybe in here in the body. So the patient, the person can be disabilitated, bedridden. So this is very, very important. And this is actually rising throughout the world because of the life expectancy that that is gradually increasing, and now we can expect around 80 to 90 years of your survival. And so the bones becomes porous because of the age per se, and so this is gradually increasing, and India is even not the exception. Particularly the rural population is again very much prone to develop this one, which is a misconception that the rural population is not suffering from osteoporosis, but around 100 million people per year is actually suffering from this osteoporotic fracture every year in India. And if you see, there is a osteopenia prevalence is 52% and osteoporosis is 29%. It is much higher than the counterpart developed countries. And this is actually the changes that occurs in the bone. That bone becomes porous, that is, there is a decreased bone mass, there is decreased trabecular thickness, then the other component of the bones are actually getting very less, so bone becomes porous. So this is a normal bone, and after that, then the osteoporosis, there is a moderate, you can see that the porosity is increased. And if you see the gross osteoporosis, the severe osteoporosis, there is nothing left as a mineralization in the bone, and so ultimately it is a fragile bone. This is severe osteoporosis. So there are some modifiable risk factors, the non-modifiable risk factors I have already mentioned. That age, the increasing age is the predominant factor for the osteoporosis. Like female sex, the maternal family history of hip fracture, low birth weight, disease predisposition to osteoporosis like Paget's disease, which are non-modifiable risk factors. But the potentially modifiable risk factors are very, very important, particularly the addiction like smoking, alcohol. Then the dietary calcium and the vitamin deficiency. These are the very common thing that we can easily modify so that the osteoporosis can be prevented. Then if you look at this particular picture, there you can find that the vertebral fracture are actually increased after age 50, particularly in the women. And the risk fracture, which is common in the younger age group, that becomes plateau. So if the vertebral fracture and the hip fracture increases, ultimately what happens, the person becomes bedridden. So that is the most important thing, that we need to prevent this osteoporotic fracture. Otherwise the quality of life will be hampered, as well as the mortality will increase. And here comes the relationship between the CKD and the bone health. Now CKD is another very important aspect. This is probably again very, very less discussed, that CKD is a very important cause for bone disorder, and that bone disorder is called CKD MBD syndrome. And this CKD MBD, that is mineral bone disorder syndrome, is defined as a combination of three particular entities. One is the biochemical abnormality, which includes the calcium, vitamin D, phosphate, intact parathormone metabolism defect. Next is the abnormalities in the bone turnover, that is either it could be high bone turnover disease or it could be low turnover bone disease. and there is extraskeletal manifestation, that is extraskeletal calcification. Here in this picture you can find that there is a calcification in the abdominal aorta, and it is now proved beyond doubt that when there is calcification in the major arteries, that calcification also involves the cardiac arteries, and there is high chance of cardiac morbidity and mortality, and that is the most important cause of sudden cardiac death in the CKD population. So this also involves with the bone metabolism and bone mineral metabolism. So this is very, very important aspect, as we are actually having more and more number of CKD patients throughout the world as well as in India. And if you see a particular area where 100 population is there, out of this 100%, at least 10 are suffering from CKD, that we actually don't know, and out of them there are significant number of osteoporosis is there, and the fracture that is also interrelated with this particular entity. So this is very, very important aspect, that we should have a awareness about the CKD and the CKD osteoporosis. That's why I took this topic to discuss over here. I am not going in detail, in depth about this, but there is, as the CKD advances, the CKD stage 3 crosses, there is increased chance of this CKD MBD, and there is a problem with the osteoporosis and the CKD MBD. Now, there is a particular difference between the CKD MBD and the classical postmenopausal osteoporosis. Like in osteoporosis, postmenopausal osteoporosis, you will not have significant abnormality in the calcium, phosphate, vitamin D, IPTH, etc., etc. There will be mild variation. But in case of CKD MBD, it is complicated. There is significant variation of the calcium, phosphate, parathormone, vitamin D, alkaline phosphatase, etc. In osteoporosis, there is no such extraskeletal calcification which increases the cardiovascular morbidity, mortality. But in case of CKD MBD, there is increased chance of getting the extraskeletal calcification, there is a cardiac calcification, and so the chance of getting cardiac disease is very, very high. So this diagnosis and management of osteoporosis in CKD is very, very important, because as the ESRD increases, the chance of getting fracture is high, and as the age increases, the ESRD increases. So this is interrelated. But the challenges are, the assessment of fracture risk and osteoporosis in CKD is very, very difficult. It is not straightforward like in case of postmenopausal osteoporosis. Just do DEXA scan and you can find osteoporosis. Here you have to assess whole spectrum, and after that you have to go for DEXA, and then you have to assess the osteoporosis. And second is, the management of osteoporosis in CKD is again very, very difficult, challenging, that will come. So in case of CKD, you have to go for assessment of CKD MBD plus osteoporosis. So what are the modalities? Modalities are the calcium assessment, the vitamin D assessment, PTH assessment, and the bone turnover marker like CTX, P1NP, etc. And there are bone osteoporosis measurement like DEXA or CT scan. And there is a combination method, it is called FRAC score, along with the history and others. So these all can be incorporated for assessment of osteoporosis in CKD patient. And what is BMD? It is nothing but the bone mineral content of a particular bone. I'm again not going in detail, but T-score is very important, as it is T-score which defines osteoporosis. So T-score means it is a particular amount of bone you have when compared with a young adult of 30 years old with the same gender, with a peak bone mass. So with that you have a T-score, and Z-score is in the same age group. Now with this T-score, we have a definition of osteoporosis, that is by WHO. When the T-score is below -2.5, it is called osteoporosis. When it is -1 to -2.5, it is called osteopenia, and 0 to -1 is normal. So when it is -2.5, this is osteoporosis. This is actually a straightforward diagnosis by DEXA scan in postmenopausal osteoporosis. So that is there. But in case of CKD MBD, you have to have a different combination. So that is the change that happened in 2017. Earlier, the concept of CKD was, that the only when you find that calcitriol is given in the prescription, it is nothing other than CKD management. So that all are changed now. So since 2010, 11, 12, we have lots of paper that have identified that the assessment of DEXA scan osteoporosis in CKD population is actually significant. And since then the concept changed. In 2017, KDIGO told that you have to go for DEXA scan for osteoporosis assessment in CKD population if it modifies the particular therapy and the quality of life. So this is the milestone in 2017 that achieved, and that is the awareness started to grow for the development of osteoporosis, detection of osteoporosis and their management of osteoporosis. So next comes the risk of fracture score, means fracture risk assessment combination of method. There is a FRAX score or the FRAX tool. Again, I am not going in detail. FRAX tool is available online or offline. You can download anywhere in your computer or in your mobile, and there different parameters are there like age, sex, weight, height, previous fracture, parent fracture, hip, current smoking, glucocorticoid, rheumatoid arthritis, secondary osteoporosis, alcohol, 3 or more units per day, femoral neck, etc. Now after that you can have that data, and with that you have a risk factor assessment score. So with that NOF guideline is there, where it is told that if it is more than 20% of risk, then it is a major risk factor, and if it is a more than 3% hip fracture, then it is a significant risk factor for osteoporosis in particular patient. With that, you can have a good assessment of a prediction of fracture due to osteoporosis both in CKD, MBD as well as in the normal population. So this is another very important message, that you have to use this FRAX score for assessment of fracture risk in a particular population. Now coming to renal disorders and the burden of osteoporosis. So as osteoporosis and CKD are more prevalent with aging, so you have more and more osteoporosis in older age group population. This is very easy calculation, is directly proportional. But the cause for this reduction in the bone strength in CKD are multifactorial. Particularly, it is the reduction in the 1,25-dihydroxyvitamin D. That is the active vitamin D deficiency is there in the early stage of the CKD, and as the CKD advances, there is more and more deficiency of this active vitamin D, and there is increased PTH, and so there is a high turnover bone disease along with this low active vitamin D. So there is increased turnover and there is increased fracture risk, and there is abnormal mineralization. In post-transplant osteoporosis, again a very important risk factors because of the increased burden of steroid as well as the previous burden of CKD osteoporosis before transplantation. So with that, you have around 22.5% to 30% of increased fracture risk, major fracture risk in 3 years to 5 years post-transplant period. And we have seen lots of patients after post-transplantation, the patients are becoming bedridden because of this fracture. So this is another very important area. Now, so the message is osteoporosis seems to be an important issue to be handled seriously in nephrology clinics in our day-to-day practice also. Coming to next part, that is managing osteoporosis in CKD is another challenge. Here, when you are identifying osteoporosis in CKD, you have to assess the bone turnover. The bone turnover can be identified by bone-specific alkaline phosphatase. If the bone-specific alkaline phosphatase is high, it is the high turnover bone disease. If it is low, it is the low turnover bone disease. And if it is normal, then it is a normal turnover bone disease. In case of high turnover bone disease, you have to go for the anti-resorptive therapy. In case of low turnover bone disease, you have to go for teriparatide, anabolic therapy. And in case of U turnover, normal turnover, in that case, it is very difficult. You have to go for bone biopsy to find actually what is happening inside the bone. And depending upon that, either use anti-resorptive or the anabolic therapy. This is in a nutshell the therapy. The problem is here, the therapy that is available in osteoporosis treatment like bisphosphonates is very difficult to use in case of CKD because it is a high chance of getting more and more CKD. This is a risk factor of worsening CKD. There is increased chance of jaw fracture, osteonecrosis of the jaw. There is chance of getting hypersensory reaction. There is high chance of getting low turnover bone disease by using these bisphosphonates. So bisphosphonates are not safer or very difficult to use because less than 30 GFR, you cannot use bisphosphonate. Next, the parathormone. The parathormone problem with the parathormone is that there is high chance of hypercalcemia, and with that hypercalcemia, the patient may die or patient will have more and more kidney failure. So again, it is not safer to use this parathormone in case of CKD, MBD. So what left? No other options available till the availability of one particular molecule that is came up. It is called denosumab. This denosumab has changed the paradigm in the management of osteoporosis in general population as well as in the CKD population. So this denosumab is nothing but a fully monoclonal IgG antibody against rank ligand. Again, I am not going in detail about this rank ligand. What does rank ligand do? It actually increases the activity of osteoclast so that the bone resorption does occur. Now, if the rank ligand can be inhibited by this denosumab, then this activity of osteoclast will be prevented, and ultimately the bone resorption will be prevented. And so this is the actual therapy. So this is a actual a remarkable change in the therapy for the osteoporosis. So here is the denosumab. The denosumab can be used in case of postmenopausal osteoporosis, can be used in case of glucocorticoid induced osteoporosis, can be used in case of male prostate cancer like therapy. When you are using, then osteoporosis, you can use this in this particular patient. And in case of CKD MBD, where osteoporosis, where no other therapy is actually safer. The dose is 60 milligram every 6 monthly. You can use up to 10 years. Contraindications are hypocalcemia, pregnancy, and known hypersensitivity. Clinical evidence, again, I am not going in detail. This is a freedom study. It is the largest ever study with the 8,000 odd patients, and they initially took for 36 months. Then it is extended up to 10 years. And there it is significant improvement in the new vertebral fracture. That is 68% risk reduction in the new vertebral fracture, 20% reduction in the non-vertebral fracture, and 40% reduction in the hip fracture. So this is a significant improvement in the risk factor reduction. So, and this actually continued till 10 years that the therapy was given. But one consideration is, when you stop this therapy, immediately within the first 6 months to 1 year, again there is a increased chance of getting fracture because of the decreased bone mass. So this is another very important aspect. After stopping this denosumab, you have to use another therapy so that the patient should not get fracture post stoppage of the denosumab. Now, these are the different agents that we can use in CKD, but these are not safer. I am not going in detail. This denosumab was tried in dialysis population, in post-transplant population, as well as real life in CKD non-dialysis dependent population. And each and everywhere it was shown that this denosumab is number one. It is safer. It can be used in case of dialysis patient where it will not induce high turnover to low turnover bone disease. Actually, it maintains a good turnover bone disease when bone, and it make a bone strengthen more than if you use other agents like zoledronic acid or other bisphosphonate and other agents. So this denosumab can be used in case of dialysis patient safely, in case of pre-dialysis CKD patient, advanced CKD patients safely, and in post-transplant CKD patients. And if you see, I am working in this denosumab molecule in our department. We have just completed a 1-year thesis on that, and we have got a 10 patients data of 1 year. Now it is more than 1 year. There is a significant improvement in the DEXA scan. Number one, within 1 year of therapy, there is significant reduction in the dose, in the risk reduction of the osteoporotic fracture in 1 year period, and there is no such adverse events that happened throughout this 1 year period. So denosumab can be a game changer in the treatment of osteoporosis, both in the normal population, postmenopausal osteoporosis, as well as in case of CKD osteoporosis treatment. So I am concluding by giving this take-home message that number one, osteoporosis diagnosis and its management is critical but difficult issue in case of CKD. Denosumab may be the drug in treating osteoporosis in CKD patients, but it needs more studies confirm its effect on bone dynamics or turnover, as chance of dynamic bone disease is a theoretical possibility. Thank you. Thank you for patient hearing.
Good evening to you, ma'am, and all of you. I am Dr. Tridibes. I did enter in MBBS in Medical College in 1993. And I have done my urology training from Bombay. And I am a consultant in Apollo Clinical Hospital, Kolkata. Now it is Apollo Multi-Speciality Hospital. In fact, the robotic surgeries in Eastern India started by me and Dr. Mahendra. And we have doing robotic surgery since 2011. So we are we have done few robot recipient also. And most of our donor is almost 90% of our donor transplant is basically robotic. So today I choose a topic which is not a urological topic. I thought I'll be talking very general, and then so catheterization is an integral part of treatment, and indications are basically critically ill patient in ICU, monitor urine output, neurogenic bladder, incontinence of urine as a part of investigations, pre-operative, post-operative patients, and in urinary retention. So what is the problem? So catheterized patient place them in a significant danger of occurring UTI. So if you see any person who is having a catheter for longer time, they always get some of the other time that is UTI. So even the best catheter care, most will have an infected urine after 10 to 14 days. So why it is significant concern? Because it's increased the morbidity of a patient by threefold. If the patient is in the hospital, that increase the length of hospitalizations. It increase the risk of surgical site infection if they have an UTI. So we have to take care of it. So the risk factors are if the catheter related, like left in place more than 6 days, inserted in a place other than OR, not positioned correctly, drainage tube above the bladder, below the level of drainage bag, at not maintained in a closed system. And if you think about the person's personal individual factors, then if it is a female, the urethra is small, in pregnancy, elderly, if they have a diabetes, having azotemia, some foreign body like stains, and other site infection if it is an immunocompromised. So these are the persons who can get in UTI more. So diagnosis of catheter-associated UTI is based on the findings bacteriuria along with elevated WBC on urine analysis. In some cases, the elevated serum WBC and 2 or more of the following signs and symptoms are present. So they complain of pain, burning in the region of the bladder and urethra and flank. They can have fever, chills, malaise. The odor of the urine will be more offensive, change of color, they become cloudy, they can have hematuria, they will have bladder spasm and leakage around the catheter, increased weakness and spasticity, especially in those neurological patients, change of mental status, particularly in older age groups. They become more confused. If you see at UTI patients, the elderly people, they can become really confused, and bacteremia. So these are the common organisms: E. coli, Klebsiella, Proteus, Enterobacter, Pseudomonas. So all of us knows, and it can be some fungal infection, chlamydia. So the most common infection in acute hospital and long-term hospitals, 15 to 25% of hospitalized patients are catheterized, and most notable complications associated with indwelling catheter is development of nosocomial UTI, and that accounts about 40% of the nosocomial infections. And if you see, there are studies in the hospitals, and they have shown the length of antibiotic therapy, the times are higher if the catheterized patient and then the non-catheterized patients. And catheterization is the second most common cause of nosocomial bloodstream infection as well. So what are the issues? It can be pre-catheter, during catheterization, and post-catheterization. We do concentrate on the pre-catheter, but during catheterization and post-catheterization, people do get lot of issues. So care must be minimized to risk of infection and smooth catheterizations leading to the patient comfort. Care to minimize the chance of getting UTI and ensure patient comfort. And post-catheterization, so they do get irritation of the and urinary symptoms after removal of the catheter, and they sometimes get UTI as well. So what you have to do? You have to realize this is a foreign body and can cause patient discomfort, and that leads to bladder spasm. And they, following any surgeries or anything, bladder spasms caused by the irritations of the bladder mucosa, presence of a urinary catheter leading to irritation symptoms like suprapubic pain and irritation. Severe studies have shown a direct correlations between increased bladder spasm, leakage, and infection. So the flavoxate is a medicine pre-catheterizations we can give. It causes smoothening and comfort of the catheterization throughout the bladder by calming effect. Bladder spasm triggered by the irritation caused by the catheter can be relieved by drugs which relieves bladder spasm as like flavoxate. Flavoxate has an local anesthetic and analgesic effect. So basically, if we know that this guy will require a catheterization and we know this patient is more complaintful or like they get more pain and burning, so it is better to give a flavoxate before catheterization. So catheterization should be done in a sterile aseptic condition. Select a catheter which is the smallest size and inflate the balloon as less as possible. You can put just 10 ml or 8 ml to indwell the catheter. Minimize duration of the catheterization, so don't keep the catheter until it is required. And routine perineal catheter recommended. Sometimes we had seen during our student life that someone put some betadine gauze around the catheter and left for till the time you don't remove. Like that should not be done, because a lot of secretion, periurethral secretion comes and leads to infection. So in patient catheterizations with catheterization, the catheter irritates the bladder, leads to spasm of the detrusor muscle, and the force generated by the spasm of the detrusor overwhelms the drainage capacity of the catheter, leads to catheter. So at least we have seen during my childhood, like if anybody is leaking periurethral catheter, we used to like put a bigger size catheter. It is our like that was the concept, or maybe increase the balloon capacity. But believe me, both will have a opposite effect. If you increase the balloon capacity, it will increase more irritation, and if you put a bigger size catheter, that also will increase the irritation that leads to pericatheteral leak. So that's the way. Now that leakage, if it is there, we can give some anticholinergic medicines or like flavoxate. Now there are a few other medicines available, sulfenacin, mirabegron. These are the medicines which can be used. So this is the same algorithm which I was talking about. So and now come to the management. Like antibiotic treatment, you will often appear to eradicate the infection organism, but as long as the catheter remains in place in the same organism or the other may quickly return. So basically what is they are trying to mean, if there is an infection you found by culture, don't necessarily have to treat aggressively until unless there is a symptoms, because if you give antibiotic may go, but it will return till the catheter is there. But if situation arises you have to give antibiotic, then low dose of nitrofurantoin is a good drug which can control the growth of the bacteria. So now come to the catheter-associated UTI management. This can be asymptomatic and symptomatic. Now come to the asymptomatic. So most causes of bacteria during catheterization can be asymptomatic. Asymptomatic bacteria is inevitable in catheterized patient and healthy individual. These infections clear spontaneously after catheter removal. So you don't have to treat. You remove the catheter, they will go. Exceptions are immunosuppressed and those with bacterial endocarditis or any other foreign body, pregnancy, elderly. And in those cases, you can use nitrofurantoin 50 milligram. Now come to the symptomatic patient. So you have to treat two things. One is the infection and one was the symptoms. So elimination of symptoms is initially treated by empirical, but choice of therapy with antimicrobial drugs should be based on the culture sensitivity testing, urinary antibacterials like antibiotics like nitrofurantoin, norfloxacin, ciprofloxacin, amoxicillin, cephalexin. And in fact, if you follow a urine culture pattern, you will find out that these are few drugs which is particularly sensitive on those particular area. It actually differs the culture sensitivity pattern also in different places. So you can follow that and you can start the antibiotic as per that. The choice of empirical therapy should also depends on the low resistance rate against the potential pathogens, achieve significant urinary concentration. So we have to choose a drug which urinary concentration is higher. So regarding the acceptable resistance rates, IDSA recommends an antibiotic for an empirical therapy will only if below 10 to 20% of the patients are resistant to it. So most patients are treated for at least 10 to 14 days. So basically, if you are treating a patient, you better give at least 10 days of antibiotic. So one more thing I just want to highlight in there is this old publications in BJU, British Journal of Urology, 2008. The level of fluoroquinolones is thought to be inappropriately excessive and will eventually have a detrimental impact. Believe me, we used to give lot of fluoroquinolones during our student life. Now we are using less. Quinolones has some other effects also. They cannot be given for longer time. They cannot be given in pregnancy as well. So the treatment of catheter-associated UTI consists of elimination of infection by antibiotic and relief of symptoms by some medicines. So let's come to the post-catheterization. Following a catheter removal, irritative urinary symptoms may persist, and European PMS data suggest that these symptoms may persist for 5 to 7 days. And again, in these particular people, you can give some anticholinergic like flavoxate to relieve the symptoms. So appropriate indications for chronic indwelling catheter, urinary retention, prevention of contamination of wound, comfort for terminally ill patients, and requirement for post-surgical care. So let's come to the summary. Indwelling urinary catheter is a major risk factor. Catheter-associated UTI results in increased risk of complications and morbidity. And the risk of acquiring UTI depends on the method and duration of catheterizations and the quality of catheter care and the host susceptibility. Thus, optimize patient's care with minimize the propagation of resistance. Thank you very much.